So let's just get started. If each of you could just take 2 minutes, tell us what you do each day, what your main focus is, what's on your mind, what is the main thing for the last 10 years and up till now that you do, you're focused on, and that you spend your time on in regards to health and lifestyle. Each of you could share, give us a 2-minute update.
I'll start off. I'll go first. Today's a typical day for me. I had my day started off with some review. Of course, I gave a talk this morning, but my day consists of doing work in my clinical practice. I'm a board certified cardiologist trained in internal medicine cardiology and cardiac electrophysiology. I practice in the Texas Medical Center. It's the world's largest medical center. My background is such that I went through many years of training and became entrenched in the standard way of treating. And I became aware of alternative lifestyle therapies well into my private practice. And I think God had it such that, I became entrenched in one area and then learned all of this information in terms of plant-based nutrition and other aspects of lifestyle that was very important. So that I was able to speak that message while being entrenched in this area. So my day-to-day operations consist of seeing patients in the clinical practice. We do our own clinical research. We've published our works of the data we've seen for thousands of patients over nearly 2 decades. We do minimally invasive testing in the clinic in our center, just 4 miles south of the world's largest medical center. And I do some clinical work inside the hospital, managing patients with advanced heart disease. And we specialize in utilizing the acute intervention of nutrition and lifestyle methodologies in the acutely ill patient, trying to resuscitate them in many cases, as I've shared with the audience this morning. So that consists of our work, clinical research, and also building a program for the healthcare center of the future. We have our on-site nutrition center, and we do things like that to help our patients turn their lives around. That concludes my comments.
Go ahead. Anyone next? Anyone who wants?
I'm happy to go. I'm Dr. William Lee. I'm the president and medical director of the Angiogenesis Foundation. It's a pleasure to be on this panel with my distinguished friends and colleagues. I'm an internal medicine physician that has been spending the last 25 years really looking at vascular health from the perspective of angiogenesis, which is how the body grows blood vessels. Blood vessels are a 60,000 mile channel series of networks throughout our body, and they deliver oxygen and the nutrients that we eat to pretty much every cell in our body. And I spent the majority of my career involved with biotechnology and trying to develop better medicines to treat blood vessel dependent diseases that range from cancer to diabetic complications to vision loss, and cardiovascular diseases, as Dr. Montgomery was alluding to. There's about 41 different therapeutics that have emerged out of the work that we've been doing. So it's been very productive. But the science is continuously changing, and so is the burden of disease. About 10 years ago, I began looking at the role of diet in health defense systems, including angiogenesis, but also other interconnected biological systems of the body, ranging from our stem cells for regenerative health, our microbiome, how our DNA protects itself, as well as our immune systems. And that led me to write a book called Eat to Beat Disease. But I'm actively now involved with programs at the federal level, trying to improve nutrition at the national level with the USDA, the NIH, exploring the creation of a more national institute focusing on nutrition. And last year, when the pandemic hit, I sort of jumped into the deep end of the pool and became a COVID researcher, which is a field that had no experts because humans hadn't seen this disease previously. And so I wound up actually being one of the members of the discovery team that found that the coronavirus also infects our vascular cells and causes a microvascular disease primarily, in addition to a respiratory disease, which then explains many of the complications of COVID. So now I'm actually collaborating with groups in academia and government, including the FDA, as well as a variety of biotech companies and nutrition institutes as well, looking at how we can help reduce risk, help to combat the disease itself, and then recover, especially from the syndrome that's known as long COVID or post-acute sequelae of COVID, or PASC, as it's now being called, because that's a condition that can affect conservatively about 30% of people that have recovered from COVID. So my day is pretty busy juggling these 18-wheelers.
Dr. Campbell or Esselstyn?
Yeah, I'll take a crack at it. I'm actually now struggling to retire. I'm still working now just about as much as I did when I retired, so to speak, 20 years ago, and just published a book just last month. And interestingly, all of these three colleagues of mine endorsed the book, and so it's really a pleasure to be here with you guys. But in any case, I spend most of my time just thinking about how to write something, how to say something regarding the science of nutrition. You know, the science of nutrition has been badly butchered for decades. And I often wonder and worry a bit about how this happened. The book that I just finished writing, in fact, with my grandson, is really a question concerning, you know, where did we go wrong as far as nutrition is concerned? I know there's a lot of different kinds of disciplines we think about, of course, in medicine and healthcare, and I would argue that just the food we put in our mouth and understanding what happens to that food and how all things work together is pretty critical. So not understanding nutrition has its implications for all sorts of non-scientific, if you will, non-biologic, I should say, issues, climate change, even cost of health care, that sort of thing. So I just basically am publishing some papers. I just came out one, since COVID was mentioned, I just came out with one on data from China that we explored some 30 years ago, having to do with the role of nutrition on the virus, the hepatitis B virus, as it causes liver cancer. Got some results that were absolutely spectacular in those days. It could not be more prominent. You know, plant foods stimulate antibody formation and prevent the virus from causing liver cancer, which is this basic symptom. Animal foods, in turn, at very low levels, only about 10% on average what we do in the West. It was highly significant related to the production of liver cancer and maintaining an active virus. So I've gotten excited about that, writing some more papers, and just sort of pointed that out as one of the casualties of nutrition. Since we know so little, it seems like to me, or understand nutrition, when something like this comes along, it seems like nobody's asking questions, to my knowledge. You know, what role does nutrition really play in these viruses, other than, you know, presenting comorbidities, obviously. But aside from that, what does that have anything to do with this? And I'm excited about telling that story. That's what I do.
Thank you. Oh, you're muted. You're muted, we can.
How's that? Any better?
Yes, good, thank you.
Thank you. Dr. Esselstyn. I direct the Cardiovascular Disease Prevention and Reversal Program at the Cleveland Clinic Wellness Center for Disease Reversal. And I guess I'm really very excited to be in the company of cardiologists, because I always have a chance to learn so much. I should confess, though, I got very interested in cardiovascular disease. My training was as a background as a surgeon, and I was a surgeon at the Cleveland Clinic for 31 years. But halfway through my career, I got kind of waylaid because I was so disenchanted with the fact that for no matter how many women I was doing breast surgery, because at that time in the late 1970s and early 80s, I was chairman of the breast cancer task force. And no matter how many women I was doing surgery for, I was doing absolutely nothing for the next unsuspecting victim. And that led me to do a bit of global research, and it was quite striking to find that we have known for over 100 years that there are multiple cultures on the planet Earth where cardiovascular disease is virtually non-existent. And I just thought there would be more bang for the buck if we could somehow show people how to eat to save themselves from ever having, or perhaps if they do have it, reversing their heart disease. At the same time, we would really have a remarkable decrease in the amount of the Western cancers of breast, prostate, colon, and pancreatic. And I kind of knew we were on the right path when I remember I only had about 24 patients in this first group because I was so tied up with my surgical practice. There wasn't time for a large group. But in 1986, I knew we were on the right path because there was a gentleman who, walking over the Skyway to my office, he had to stop 5 times because of pain in his calf muscle because of a partially blocked artery in his thigh. So he went on this rather significant plant-based nutrition that we were sort of borrowing from these other countries without any oil. 10 months later, because I had been so focused on his heart, I totally forgot about his leg. And 10 months into the study, he said to me one day, Dr. Esselstyn, do you recall when I first started seeing you, I had to stop 5 times crossing that Skyway to your office. He said, the last month, I don't stop. The pain is gone. So I said, Don, back you go to the vascular lab where we had an original pulse volume at the very start of his treatment. Now, 10 months later, we repeated the pulse volume with the pain gone, and the pulse volume was now double what it was. We now had absolutely rock solid, irrefutable science that food and food alone could halt and reverse this disease. And somebody's going to say, well, wait a minute. What about those statin drugs? Well, this is 1986. We didn't have any statin drugs. So I think it's so important for people to recognize that if there are situations where they cannot take those drugs or statins or what have you, they are in no way precluded from enjoying similar benefits provided they follow the program appropriately. Thank you.
Okay, great. So I want to jump into maybe one of the biggest questions I could possibly ask. The question is, and this is the question that I guess people come to listen to this panel for. The main question is, what should we do to prevent cancer? Can it be prevented? What about if you already have early stage cancer? Can it be beaten with lifestyle and natural non-invasive methods? We understand that there are brilliant oncologists that we could go and they could tell us all about what to do if you have it. But what should we do to prevent cancer? Can it be prevented? And what if you already have an early stage cancer? Can it be beaten with lifestyle, diet, and natural non-invasive methods? Any of you can answer that.
Well, I'd like to take a crack at making a comment here on this. One of the things that struck me first about this question of diet and cancer, way many years ago now, gosh, in the, I guess early 60s, early 70s, there were studies coming out at the time that showed, and these were correlation studies, and we know the difficulty of understanding correlation studies, but nonetheless, when countries were compared around the world with halfway decent data, the linear regression between cancer and, let's say, saturated fat, which I would argue is mainly a surrogate for animal food consumption, the linear regression actually was such that the line came right down through the XY origin. It was a straight line relationship almost. That then was repeated 3 or 4 times after that by other researchers, and And so there it is. It's really stark, that relationship. Obviously, it doesn't say much about, what is the connection, if you will. But when exploring it from various society different perspectives, it was clear diet played a major role. And then as to how it worked, that's where I spent a good part of my time in my career, was trying to understand, the mechanisms as to how diet might work. We got some ideas on that. So I would argue that the role of diet, and let me call it nutrition, I prefer to call it that, the relationship of nutrition with the prevention of cancer is pretty impressive. It really is. The problem comes up as to what do we do with cancer patients, of course. I'm not a clinician, so I don't have a chance to participate in that sort of thing. But my youngest son, who co-authored the book with me, has just now got a really pretty exciting study on stage 4 breast cancer at the University of Rochester going right now. And so far seeing some pretty respectable results, it seems to me. But that's the link that's missing, Steve. We see these overarching data that tells us, hey, there's something here. It really is pretty impressive. It's not due to one nutrient, I would argue. And it's a constellation of effects of a particular kind of diet, rich in animal protein and lacking in the plant protein, if you those foods, as far as causation is concerned. But we got some work to do on the cancer thing. If we can just figure out a way to do these kind of intervention studies. Clinical trials are hard to imagine to some extent, but to do the intervention studies that are going to be required to understand whether or not nutrition can play a role in people who've been diagnosed with cancer. We can't really answer that very well at the moment, hardly at all. Unless one of my colleagues want to offer something. But
I think Bill had some comments. I'll go last.
I'm happy to weigh in on this. Building on what Dr. Campbell just described in the prevention setting, I actually take care of cancer patients, and also really prize and prioritize the understanding of how to prevent the disease itself. So we have so much emphasis on genetic diagnoses. You go to these different clinics to do cancer screening. And that's an important thing to do. We know that there are genetic links to colon cancer and breast cancer, pancreatic cancer, ovarian cancer. There's genes like BRCA and et cetera. And those are actually really important things to do. But in reality, only about 5 to 10, probably closer to 5% of cancers are genetically spawned. So that leaves 90 to 95% of cancers that are really more attributed to our lifestyle and our environment, not just in the last year or two, but really over the course of your lifetime. And that speaks to the importance of a lifetime of lifestyle and that the changes that can occur in the body happen over a long period of time. One of the things that I actually study is an interesting involution of the question, why do we get cancer? We know smoking causes it. We know too much ultraviolet exposure causes it. We know that chemical exposures can actually cause cancer as well as radiation. But actually, a more interesting question is, why don't we get cancer more often? Why is it that we get cancer only when we're older, when we tend to actually have these noxious exposures, when in fact our entire body is insulted throughout the course of our lives? And so that's led sort of to a very interesting investigation on how the body actually resists cancer. So we know that cancers depend on a blood supply. We know that our body can actually prevent excess blood vessels from growing to feed a cancer. We know that cancers actually establish and then renew themselves using stem cells. We also know that there are vulnerabilities to stem cells, some of which are actually can be actually driven to extinguish a cancer stem cells, that dietary in nature. We know that our microbiome actually also influences inflammation, influences our immune system, and both of those actually are tied too much inflammation to cancer and poor immunity to the development of cancer. And of course, our DNA, which is subject to mutation. Most people don't know that, we talk about tanning salons being bad for us, but even people that stay indoors have on average 10,000 genetic DNA mistakes that are made every single day. And fortunately, our body can repair those mistakes so that we don't actually have consequences that are at least noticeable. And then finally, our immune system, we do know for a fact that when our immunity is down, we are more vulnerable to cancers. For example, HIV, immunosuppression can actually lead to higher rates of cancer. But what's really interesting to me, as somebody who's been involved with drug development for cancer drugs, is that we can use immunotherapies to tank up someone's immune system during cancer, during the battle with cancer. And we can actually, in some cases, use our own immune system to wipe out cancer, even metastatic cancer. And that is also influenced by diet. So I think that, one question is really, why don't we get cancer more often? Oh, because our body is actually well equipped to actually resist cancer on a daily basis. But these insults that occur, which may be dietary in nature, over amount of saturated fats and salts and so on and so forth, can be a negative factor. But then the flip side of it is the healthier diets, which, Dr. Campbell wrote about long ago, actually may be able to tip the balance in the other direction to assist the body in resisting disease.
Well, although I'm a cardiologist, we've been having to manage patients or provide nutritional support for many patients with cancer. Many of them have heart disease in addition to other chronic illnesses. And, I think the comments of both my colleagues, Dr. Lee and Campbell, are on point in the sense that we clearly see that individuals on high animal protein diets who have high chemical exposure, and of course, both of these things lead to an abnormal microbiome. And in my discussion earlier today, I talked about some of the underlying pillars of chronic illness as well as acute illness, of which cancer is a part of, is inflammation, excess oxidative stress, and an abnormal microbiome. And these things work in concert to sort of break down our body's architecture. And so, cancer builds the underlying foundation for chronic illness in general. Cancer in particular builds up over time. Our experience with cancer patients, most of the people that we see come in with a myriad of diseases. They have heart disease, kidney disease, liver disease, and oh, by the way, I was diagnosed with cancer. And I don't want to undergo chemotherapy, et cetera. And so our approach is an aggressive nutritional regimen. We use a raw plant-based diet, a defined plant-based diet. We have a food classification system, so we're very precise in the foods that they consume and don't consume. It consists of, high amounts of leafy greens, superfoods such as algae, powdered greens, organic substances, sea vegetables, and the like. So we try to shower the body with heavy micronutrients in our pharmaceutical nutrition center. So we start from that approach. The next approach will be to use selected nutraceuticals or supplements on a targeted basis. We've used intravenous vitamin C at modest to high doses, liposomal formulation. We give other antioxidants such as MSM, different things that help decrease oxidative stress as well as decrease inflammation. This is a very similar protocol that I use in my advanced heart failure patients, as well as my patient with advanced inflammatory disease. And we've had good outcomes. Many of our patients who undergo chemotherapy during this adjunctive nutritional support regimen, one, they tolerate chemotherapy much better. Two, they go into remission much faster. Three, some of the other in-organ damages or abnormalities recover. One thing we're dealing with cancer is that it overtakes the body. You have excess inflammation, excess oxidative stress, and so you start to go into a multi-organ failure phenomenon, similar to a patient with end-stage heart failure. So they start to get liver dysfunction. Why? Because they're having to take many different medications, chemotherapy being included, but they're having to take many medications due to the side effects of the chemotherapy, such as pain medication or the like. All of these things have an adverse impact on the liver, the kidney. So if you introduce an aggressive nutritional regimen, where you aggressively detox the patient, reduce oxidative stress, reduce inflammation, and reduce this chemical toxic exposure, we're able to wean many of the other collateral medications, if you will. It allows organ recovery. You have to remember the body's ability to, the number one the number one player on your team in fighting cancer is your body. It's a well intact human body, well functioning organs, well functioning kidneys, well functioning heart, well functioning lungs. So when you're fighting cancer, like any other extensive chronic illness, you're going to have to supply your number one ally with all the weapons that it needs. It needs bombers and aircraft carriers and all of these things to fight that enemy. So when you provide optimal nutrition for the body that's fighting cancer, it then turns around. It turns the tide. One, you're creating a milieu that's difficult for the cancer cells to survive in, to thrive in. And two, you're creating a defense against the cancer that will help destroy the cancer. We have patients with multiple myeloma, colon cancer, GI cancer, liver diseases, who do extremely well with optimal nutrition and other agents. And we do other things such as get them outside. They take the shoes off, the grounding, fresh air, sunshine, vitamin D supplementation. All these things work in concert in the patient who's acutely ill with cancer, and it helps turn them around.
Yeah, Dr. Montgomery, if I can ask a quick question.
Sure.
That sounds exciting and kind of impressive. Are you documenting this at the moment in a way in which you can accumulate the data, get it published and out there for people to hear?
We're going to have a conversation, Dr. Campbell, but to answer your question directly, we're documenting more in our cardiovascular setting than we are in our cancer setting. Right now, I'm working with Georgia State University. We have an upcoming study looking at the effects of our intervention in patients with known coronary disease. And we're looking at things like oxidative stress and cytokines. But what I will say is this: the information and science from that data, I think, will help us in our cancer patients, because what we'll be able to do some of these measurements in our cancer patients and look at similar things such as cytokines and measure oxidative stress and things of the like, and see how much an impact this is having. The difficulty that we have is that we're getting so many different types of cancers. And not being an oncologist, I just get them as they come. Although my cardiovascular population is more organized, I say, okay, I got triple vessel disease and I don't want to go through surgery. Manage me. But we're collecting data on more of our cardiology patients than our cancer patients. But I'd be interested to have a conversation with you, because we are seeing many more cancer patients, you and Dr. Lee, and share some war stories and maybe take some notes from you guys, because I'd be happy to collect data and maybe I can get some direction from one or both of you.
Well, I think this is certainly fascinating to hear what you all have to say, and I think it's really bearing on this major problem. I've always thought that there were two situations that developed cancer. One was initiation, and the other is promotion. And I think initiation, Bill Lee mentioned about the various factors from radiation, UV light, chemicals, smoking. And I'd like to just echo on what Baxter was saying, because when you think about it, every day in every one of us, there are billions and billions of cells that are being replaced, okay? And we don't want any one of those cells that are being replaced to lose their coherent signature, because if they do, now we're in danger of having a cancer. And it's interesting to me how slowly but persistently, I'm going to switch to cardiovascular for a minute, how consistently we've seen a plaque go away. I recently had a patient who started our program in 1917 when he was told he had to have bypass surgery, and he refused, and somehow found a copy of my book. And he got another angiogram a year later, and instead of being 80% blocked, it was now 40% blocked. And then he had another angiogram, believe it or not, same place a year and a half later, and it was now literally, you could not see the blockage at all. Now, something is really going on at a very basic level every time those cells in that plaque try to replicate. and they were turned down, and they couldn't, and it was reversing. Well, look at what Ornish taught us about early prostate cancer. When he takes the serum, you get prostate cancer cells growing in a petri dish, and you pour serum on it from somebody who's an omnivore, and 7% of those cells will regress. Now you switch and you pour serum on it from somebody who's totally plant-based, and they regress by 70%. I mean, there are some really very exciting and profound things going on here, but I think what we've got to somehow eventually do, we have really got to get down at the absolute cellular level, because once that misprint, the loss of coherence occurs, then our stem cells are sort of going in the wrong direction. I think that's where the excitement in the future is going to be.
Okay, I'd like to ask each of you a separate question, and you could each answer it each answer your own question. First, Dr. Lee. I'm going to read all the questions at once, though. Dr. Lee, what is angiogenesis? How many diseases have a similar cause? Explain what you mean when you say cancer tumors try to create blood supplies to feed themselves. How can we starve a cancer tumor? Should we stop eating all sugars, all cooked food, all fat? Should we eat just green vegetables, sprouts, raw seeds, and raw nuts? Should we eat green? Yeah, that's the question. Okay, so that's your question. Dr. Campbell, your question is, you just published a paper wherein you hypothesize a beneficial effect of plant-based food consumption on COVID-19, not just by increasing comorbidities, but by directly increasing immunity to the virus. Can you explain this? Dr. Esselstyn, you have said, you're famous for saying that we can make ourselves heart attack proof. What is the basis for you making this claim, and has it been substantiated over the last 15 years since you originally made that claim? Dr. Baxter Montgomery, do you recommend bariatric surgery for people who come to you and say, I think I need bariatric surgery? If you could each answer your questions, that would be great.
I guess we can go in reverse order. I guess we can go in order. Go ahead.
Oh, no, please. The reverse order is great.
Okay. That's an interesting question, and I get that question quite often. So the question is, do I recommend bariatric surgery? I do not recommend any surgery firsthand. So I like to look at any health condition or illness and take it in stages. So for instance, the recommendation depends on the acuity of the problem and the urgency of the need. So if someone is bleeding out at the gut, then yes, they need emergency surgery. If someone has a cardiac arrest in my office, I presented a case of that earlier today, they need CPR. I'm not going to vacillate on which green juice to give them or which green vegetable. They need surgery. They need these things urgently. But given that question in the setting where the patient is clinically stable, then I step back and I go in an order of therapeutic intervention. And first and foremost, we use a lifestyle platform. And at the core of that lifestyle intervention is going to be the food. So we use our foodceutical intervention first and foremost. So whether the patient is 20 pounds overweight or 500 pounds overweight or 1,000 pounds overweight, and there may be some indication of bariatric surgery in some of those patients with those extreme levels of obesity. But I will start off with any patient with the recommendation optimal nutrition. I want to emphasize that, and here's why. The disease state is not obesity. So let's say I'm seeing a patient that's 1,000 pounds, and they come in and says, well, Dr. Montgomery, I'm 1,000 pounds, and I really need to do something about my health. And so, I need bariatric surgery. Well, they don't have a disease of obesity. It's not obesity, not a morbid obesity. They have a disease that's related to the liking of bad foods. They start off with their desires for bad food. And so my cure for the patient, whether it's heart disease or diabetes or cancer, whatever, I'm not trying to cure heart disease, diabetes. I'm trying to cure their desire for bad food, first and foremost, because that's the core of their disease. because it doesn't matter what surgery I do, what pills I prescribe or whatever. If they maintain that desire for bad food, I can turn their stomach, that small, but they'll figure out how to get that bad food in their system and determine the stomach will enlarge. So it's the issue of whether or not I prescribe bariatric surgery has more to do with at what point do I prescribe bariatric surgery as opposed to whether I prescribe it or not. So my first approach is to get them on a lifestyle that's an optimal lifestyle. And yes, they may need bariatric surgery at some point. If I have to surgically clear them, then they're going to be in better shape to undergo and tolerate bariatric surgery if they're on an optimal nutritional regimen than if not. I was once called to see a patient. It wasn't before bariatric surgery, it was after bariatric surgery that was aborted early because she arrested on the table. And so she was in the ICU and they asked me to go and see the patient. She had a cardiac arrest while undergoing an attempted bariatric surgery. And so as it turned out, she had an ejection fraction of 10%. And so she had severe heart disease. So many people with obesity have many chronic illness because the illness isn't just obesity, it's excess inflammation, excess oxidative stress, and a poor microbiome that's creating an abnormal milieu, and that needs to be fixed first and foremost. So whether she needs bariatric surgery or needs a toenails clip is not relevant at the outset of treatment. What's relevant is to get them in metabolic condition, and so then we see how well they do. If they're 500 pounds overweight and lose 500 pounds on a nutritional regimen, guess what? I don't recommend bariatric surgery. But if they're 500 pounds overweight, they nutritionally detox themselves, and they do better to improve their overall well-being, they may be a candidate for bariatric surgery if that is needed and thought to be beneficial to improve more weight, to enhance more weight loss and the like.
Thank you. Anyone who likes.
Steve, did you have an order in mind?
Whatever order you like, whatever feels moved to speak next.
Well, let me take a crack at this question that you put to me about COVID-19. I'm glad, incidentally, Stephen, you used the word hypothesis. I hypothesized. That gives us leeway to talk about things, if you will. And because as you know, in science, we can hypothesize anything we want. We can hypothesize the moon is made out of cheese. But, so the hypothesis gives us leeway to think out loud without necessarily, convey a conclusion, obviously. So I just want to make that point because in the case concerning COVID-19, the data that we got, it's sort of multifaceted in a way, but the information we had, which was acquired more than 30 years ago, I should add, really was on hepatitis B virus, okay? It was a human study, and what we found when we compared animal protein intake as a reflection of animal foods, if you will, it's not necessarily just protein, but in any case, people consuming more animal food, and I said very, very little, that was highly correlated with the production of liver cancer. I mean, I'm talking about probability of 0.01, for example, and reflecting different ways of measuring that. At the same time, that amount of animal protein repressed inversely, highly significant, the prevalence of antibody. Okay, so we saw that with the animal protein, both the prevalence of antigen and the prevalence of antibody. Then in turn, when we looked at plants and looked at different characteristics of plants, whether it's dietary fiber or thiamine or whatever, it was just a reflection of plant intake. When we did it that way, it was exactly the opposite. Again, significant at the 0.001 level. More plants, basically no antigen, and a very high level prevalence of antibody. Okay, so that's the HBV story. That in turn is supported by experimental animal data we did at the time on mice, transgenic mice who basically were transfected with the hepatitis B virus gene, if you will. In that setting, all the animals in that particular colony, it was created by a colleague of mine in UCLA, actually, but in any case, we got a colony of mice ourselves, and they were transfected. All of them get the liver cancer, or hepatocellular carcinoma, if you will. When they're fed different levels of protein, as we increased animal protein, it had to go above the protein that was actually required by the animal for normal health. As soon as it went over that threshold, that's when the cancer grew. When the animal protein was very, very low, the liver cancer did not grow, just like what we saw in the human setting, which I found very exciting. Then we went on still in other studies. In those days, natural killer cells had just been first discovered. So I had a colleague working in that particular area. And so we had to look to see what happened with the animals consuming more protein in terms of natural killer cells. It was dramatic. The animal protein consumption decreased the natural killer cells. And then of course you can go to the plant story. So what I'm saying, I'm hypothesizing, is that this might work. If I could say it's use it properly, in COVID-19. So in that case, I started looking at some of the WHO data for different countries for the COVID-19 of the present day. And when you look at countries like Vietnam, Thailand, even Pakistan, and even, let's say, in this very difficult slum area of Bombay and India, the level of COVID cases in that case, and deaths, especially deaths, and I try to rely on rates and not just total quantity, which the media seems to like and confuse. But in any case, when we look at those countries, the level of deaths is only a fraction, 1% or less in some of those countries. In a situation where otherwise you would expect, especially with the slum area of Mumbai and in India, you would expect that the conditions for contagiousness and spread of the disease would really be bad, but it's not. In those cases, and especially in that slum area of India, none of them eat any animal food, quite frankly. They can't afford it, for one thing. I've been in those areas. And of course, they have a religious prohibition against it. So it's a setting where all the other constellations of effects that exist, environmental effects exist, to actually, suspect a very high level of COVID-19. It didn't happen. It didn't happen. So I'm taking my data from the experimental animal data and from the human data on HPV, and I'm basically hypothesizing. I actually believe there's a good probability that this could work on COVID-19 as well. In fact, we got a study undergoing, one of my colleagues is working with us, is organizing a study on that right now. So accessing as large a number of people who are consuming this kind of diet, just to see if they've experienced the disease first, and secondly, if they did, what were the symptoms. I'm very excited to see that, but I don't want to. I want to be very careful about this because, as we all know, this is a very sensitive topic. And so what I'm trying to say is that just because it's so sensitive, that doesn't mean we have to shut up and not say anything. I'm speaking out. This is a hypothesis, a possibility, and we already know that a plant-based diet is pretty effective in creating immunity, innate immunity, if you will. It's continuous too. You get on this kind of diet, stay with it. You don't have to worry about coming and going as to whether or not. So that's my story basically. I just I'm excited about the possibility that we really may have something here. It's an opportunity, and it turns out this formula, if you will, strategy, protocol, whatever you want to call it, it's the same thing where you guys are using for heart disease and others are using for diabetes and everything else. It's no different. One more last thing. It come back to, I think Dr. Lee said this here before. I've always busied myself with thinking about mechanisms, being in the biochemistry area, trying to understand the relationship between cause and effect, let's say in these complicated situations. One of the things I've gotten really excited about, namely, I spent some years looking for the mechanism responsible for the effect of animal protein on the formation of hepatocellular carcinoma, initiated by a carcinogen. I found a mechanism. First thing you know, we found another one. We found another one. I kept on going. Every time we looked for a mechanism, we found one. In some cases, it was repressing DNA repair. That was really sharp. Animal protein represses DNA repair. Animal protein represses, I said before, natural killer cell activity. On the other hand, it enhances things like hormones that actually stimulate cancer growth. When I look at that, I just finally arrived at a point, there's no such thing as a mechanism. It's kind of dangerous to end up just talking about one thing. And I just find that concept very, very exciting. Because if we're consuming the right diet, there's something about this thing that all works together. When you're consuming plants, it works to a very broad effect. And I'm not surprised, I would not be surprised if we might actually see a really pretty good effect on COVID-19 patients. And as many of you know, this diet, when people switch to it, we see results pretty darn fast. Dr. Esselstyn, of course, and others have shown, when you put people with heart disease, cholesterol drops like a rock. You guys know that, of course, better than I. It drops like a rock in a hurry.
Dr. Campbell, you mentioned, I want to know that you alluded to some population studies where in population where people eat less animal protein, that's lower coronavirus. Did you publish that recently? I think there was a paper.
Yes, I did. I published that. It published in EC Nutrition.
And it has that population data in it, right?
Yes, it has the population data.
Wow, okay.
Like you said, it's there. I just published about, I don't know, 3 weeks ago.
Can you share the link with me, please, on my email?
Yeah.
That publication when you get a chance. I mean, you can do it later, I guess, but I'd like to look at that. Sorry to interrupt.
I'd like to get some comments from my other colleagues at Baxter as well. Tell me where I've gone off the rails, because I'm sensitive.
No, you're not. We see that in our patient with coronavirus, and we've had we're seeing a lot of patients with coronavirus, and I don't want to get into the details of it, but the long and short is simply this. I have a lot of people coming to me. They want natural treatments and the like, and we put them on a nutritional regimen. We had a heart failure patient who was morbidly obese, etc. He had started a detox program. He contracted coronavirus during his detox, and it was just a mild ailment. He was ill, didn't have to go to the emergency room or hospital. As ill maybe a day and a half or two, and he got over it. He was coronavirus positive. And he told me, he said, look, I've had pneumonias before and viruses. This is the mildest episode I've ever had in my life. And he was convinced that it was because of what he was eating. But we've had lots of cases of patients preventing and also controlling their infection very effectively with a plant-based diet. And it's, we'll start them at the onset of illness. So it's like giving them a pill, if you will. Put them on a raw detox on day one. And within a few days, their symptoms are resolved. I've had one patient I treated with a raw detox. I gave her some supplements. Within 4 hours, she was feeling better. The next day, she was back to normal. Then someone went from vomiting and passing out in the emergency room. So, we see it anecdotally, clinically, and I'd like to look at that population data that you have, because that sounds very exciting. I haven't heard anybody talk about that, and I would like to look at that that you published.
Then another option that might kind of reinforce what Colin is saying a bit, and that I don't know if you're familiar with the fact that in 1971-72 that the province of Northern Karelia in Finland was known as the heart attack capital of the world. And it was such an embarrassment to Finland that there was this enterprising, courageous young physician from Helsinki who went to Karelia, Pekka Puska. And, here they were, all these lumberjacks eating a heavily animal-based diet, clotted cream on everything, and everybody smoked. And he worked with community leaders and really with the community itself, really got the word out, was able to get the word out, had quite a tussle with the dairy industry. But over the next 30 years, the heart attack rate in Karelia dropped 85%. 85%. And the other figure that struck me most profoundly as they were giving up their animal-based diet and dairy, during that same period of time, they decreased their rate of cancer by 67%.
Okay, thank you.
Wow.
So let's
Wow.
move on to Dr. Esselstyn to answer your question, which was
Heart attack proof.
yes.
Right. Now, the way I started out this whole business of research was when I was looking to see in the globally, I was trying to find out if there were certain nations where had considerably less cancers than in the United States, and that was certainly the fact. For instance, in Kenya, breast cancer rates were 30 and 40 times less frequent. But as part of this global research, it was quite striking. How could it be that these nations, many of them had virtually no cardiovascular disease? If you look at rural China, I mean, there was a province, I will never forget, where Colin Campbell looked at the death certificates, and 250,000 death certificates, one problem, there wasn't a single patient who died of cardiovascular disease. So that was really quite striking. So looking at this in a very simplistic way, the thought would be, why don't we just try to limit patients who have serious heart disease from those foods that look like they are going to be injuring the lining of the artery, that delicate innermost lining, the endothelium. Now, what makes the endothelium so magical, and I know I hope I'm not treading on any of Bill Lee's feet here, but what makes and why was it that the three men that discovered that the endothelial-derived relaxation substance was a gas for which they received the Nobel Prize? How do you get a Nobel Prize for finding out a gas? Well, that gas had remarkable properties. It keeps all the cellular elements within our bloodstream flowing smoothly like Teflon rather than Velcro. Number two, nitric oxide is the strongest blood vessel dilator in the body. When you climb stairs, the arteries to your heart, to your legs, they widen. They dilate, nitric oxide. Number three, nitric oxide will protect the wall of the artery from becoming thickened, stiff, or inflamed, protect us from high blood pressure, hypertension. Number four, this is the key. A safe and normal amount of nitric oxide protects us all from ever developing cardiovascular disease. So literally, everybody on the planet Earth who has cardiovascular disease, whether they're from London, Berlin, Chicago, New York, or Peoria, Illinois, if they have cardiovascular disease, it is because by now, in the previous decades, they have so sufficiently trashed, injured, compromised, and turned their endothelial system into a train wreck, they no longer have enough nitric oxide to protect themselves. So my whole focus really began to be on how we could enhance nitric oxide. And that's why I think you've heard me talk a little bit from time to time about green leafy vegetables, because what has become apparent is that the endothelial production of this remarkable nitric oxide seems to be age dependent. For example, you never heard of a boy or girl at age 8 having a heart attack. Why? They've got nitric oxide coming out of their ears. However, by the time they are 17 to 34, young women and men, if you look at the autopsy study of those women and men from that age, 17 to 34, who have died of accidents, homicides, and suicides, now the disease is ubiquitous. Everybody has early found not enough for their cardiac events yet. So is it any great surprise if you build a foundation for this disease in your late teens and early 20s, that by the time you're in your 40s and 50s, we now have this tsunami of cardiovascular disease. So now the other problem is by the time you're age 50, even if you're beautifully healthy, you have now lost 50% of the endothelial production of nitric oxide that you had when you were age 25. And by the time you're 80, you now lost 70% of that endothelial produced nitric oxide. So to really try to make these patients heart attack proof, I want to be sure that they are not having a single morsel ever again past their lips that is going to further injure their endothelial cells. So we can actually try to, as best we can, with those aging endothelial cells, see if we can't goose them and prod them a little bit. And at the same time, take advantage of the new research within the last 12 years or so that shows that mankind possesses an alternate pathway for making nitric oxide. And that's why we do the following. For anybody who has cardiovascular disease, I really, I climb on them pretty hard. Although I've been told I can be a taskmaster, I've also been told that I'm not as mean as I look. But the whole idea here is I want them to chew not smoothies, not juicing. I want them to chew a green leafy vegetable 6 times a day, roughly the size of half of their fist, after it has first been boiled in water 5.5 to 6 minutes so it's nice and tender, or steamed. Then they must anoint it with several drops either of a rice vinegar or a balsamic vinegar. Why? Because research has shown us that the acetic acid from those vinegars will restore the nitric oxide synthase enzyme contained within the endothelial cell responsible for making nitric oxide. So they're going to chew this alongside their breakfast cereal, again as a mid-morning snack, again with their lunch and sandwich, that's 3, mid-afternoon 4, dinner time 5, and of course I adore it when they have that evening snack of kale. So the second benefit, when you are chewing the green leafy vegetable, it restores the capacity of your bone marrow to once again make the endothelial progenitor cell. What do? The endothelial progenitor cell will replace our senescent, injured, worn out endothelial cells. The third benefit from chewing the green leafy vegetable, the third benefit is as you are chewing that green nitrate, it is going to mix with the facultative anaerobic bacteria that reside in the crypts and grooves of your tongue. Those bacteria mixing with that green nitrate are going to reduce the nitrate to a nitrite. Now, when you swallow the nitrite, it is your own gastric acid, which is going to further reduce the nitrite to more nitric oxide. So think about it for a minute. What you're doing for literally no added expense, no hideous side effects. You are replacing from dawn to dusk, morning to night, all day long. You are replacing nitric oxide, the very molecule, the deficiency of which gave you this disease in the first place. Now, there is a caveat. Apparently, fluoride in toothpaste and fluoride in public drinking water and mouthwash will injure those beneficial bacteria. And we do not like the patients to take antacids because if you reduce your gastric acidity, you will be unable to reduce the nitrite to more nitric oxide. Now, I know you've probably wanted, and I will finish up by saying, I'll tell you what the green leafy vegetables are. They are bok choy, Swiss chard, kale, collard green, beet greens, mustard green, turnip greens, Napa cabbage, Brussels sprouts, broccoli, cauliflower, cilantro, parsley, spinach, and arugula, and asparagus. And the top 6 are kale, Swiss chard, spinach, arugula, beet greens, and beets. And that's how you get to be heart attack proof. Thank you.
Thank you. Dr. Lee, do you want me to repeat your question?
No, I remember your question. I'll get to it. And I want to make maybe a couple of comments. First, thank you to my colleagues for their incisive comments. Dr. Campbell, interestingly, in July of last year during the pandemic, there was a report, kind of a preprint report looking at 900 people in China that hadn't gotten COVID, and then followed them over the course of the ensuing months to see who got COVID. And they did some interesting things. They looked in their bloodstream to look for cytokines, including the cytokines that would have antiviral properties like interferon gamma, a natural virus killer. Also looked at the microbiome to look at what types of bacteria were growing in their poop. And they also looked at their food frequency questionnaire to find out what people were eating. So in the midst of this pandemic, there was this study going on. I haven't seen the final version of it, but the preprint was indeed very interesting because they went into great depth. They found that the people who wound up going on to develop COVID were more deficient in interferon gamma. They didn't produce as much interferon gamma, which makes sense because it's a natural virus killer. And that was the hypothesis that was actually assigned to that group that did not develop COVID. Then they've correlated the interferon gamma production with 2 bacteria that they found noticeably in those people that produced the interferon gamma. And one was lactobacillus and the other one was ruminococcus. So these two species of bacteria were made in the fecal matter and was correlated, again, hypothesis, with interferon gamma, which then was correlated with lower COVID incidence in that group. And then they looked at the food frequency questionnaire. And what they found is that the people that had more rubinococcus and lactobacillus had drank more tea, both green tea and black tea, as well as had more omega-3 polyunsaturated fatty acids from a variety of sources. And so, this kind of backs up into this daisy chain of associations that generate and support the hypothesis that you were actually making, with the additional sort of cytokine measurement in the blood. So this is the kind of thing that needs to be done more. And it actually speaks to, Dr. Montgomery's comment about the microbiome and Dr. Esselstyn's comment about sort of, how diets may actually affect multiple aspects of systems biology that could act, so that it's not simply one magic bullet, but sort of different patterns of behavior that can actually make a difference as well. So that's one. And so one of the things that I'm actually doing right now is looking at in greater detail at how various dietary factors influence those targets with COVID or the immune response against it. And in particular, something fascinating, as in this country, we're getting more people vaccinated, is that there are dietary factors like brassica, sulforaphane containing foods that actually have been shown to improve the response of the body to vaccines. We haven't done this with the COVID vaccine yet, but this has been studied with the influenza vaccine. So there was a group of young people, young healthy people, getting the flu vaccine in North Carolina, where they actually got a nasal spray of the vaccine during flu season. And they measured before and after in two groups what were their immune profile that you would expect to respond to a vaccine. And they also swabbed the nose afterwards to take a look at residual virus that may or may not be present. And the two groups were, one group that actually had, I think it was 2 cups of broccoli sprouts. These are the 3 to 4 day old broccoli sprouts, enriched with sulforaphanes that were made into a smoothie or a shake. And then another group that actually basically had a placebo smoothie. And what they found, having the shake, I think for 3 days, is that the T cell response to the vaccine was amplified. The natural killer T cell response to the people who received the vaccine and the broccoli shake was 22-fold increased.
Oh.
Wow.
And also lowered the residual virus that might be found in the nose in these people. And then they actually looked at their clinical outcomes, because they measured which people wound up getting sick and which people wound up missing work and school, et cetera. And clearly the broccoli sprout group actually had less flu symptoms as well. So again, this isn't food versus medicine. This is food and medicine, just speaking to the power of that we need to kind of decrypt in terms of our when it comes to COVID, not just for the infection, but also even for vaccination.
Right, sure.
So let me talk about angiogenesis. So angiogenesis is the growth of blood vessels in the body. It's a natural process. It actually starts in the womb. The first 3 components of our body that develop after sperm meets egg and start to form the initial clay of the human body is our fat, our adipose tissue, amazingly, our nerves and our blood vessels. So those are the first 3 things that get laid down, kind of like the background of the painting when the artist starts putting the colors down. Those blood vessels actually start out as little lakes of blood vessels, endothelial cells, as Dr. Esselstyn was talking about. And what they do is they start essentially as a blotch that then, using growth factors and stem cells and other signals that are formed during development, they eventually pattern themselves into our circulation, which is what Dr. Montgomery treats and deals with us. And Dr. Esselstyn talks about operating on as a surgeon. that beautiful blood vessel pattern that we all see in, you can look on the internet for circulation. That pattern is a 60,000-mile channel in the body, and it brings oxygen and micronutrients to every cell in our body. And the endothelial cells that Dr. Esselstyn actually was mentioning play another critical role besides forming the wall of the blood vessel. They actually directly release proteins to the cells next door in the organs in which they inhabit. That's called a paracrine effect. And basically, each of these endothelial cells are like a farmer that dumps fertilizer so that the organ in which the blood vessel is penetrating is actually being enriched and nourished. Now, when these blood vessels are damaged, as we've talked about already, over the course of age or cigarette smoke or saturated fat or high animal protein diets, as we've talked about, to sort of synthesize a little bit, those stem cells that live in our bone marrow that are residua from that formation of the embryo, because we all start as stem cells. There's some of them left, about 700 million stem cells that are still left in our bodies as adults. Some of them actually come out of our bone marrow, like bees coming out of a hive, to replace damaged endothelial cells as we age. And as we get older, we lose about 50% of those endothelial progenitor stem cells, and it's very easy to damage them from our diet. So, for example, we have a high salt diet, damages those circulating endothelial cells. We have a high diet in high saturated fat, in sort of the so-called Western diet. This has been studied in patients. It stuns actually the ability of those endothelial cells to perform. You have a hyperglycemic diet, and you have high blood sugars, actually stuns and lowers the number of those stem cells. And if you have diabetes, which is really kind of a multifactorial problem, there's also even fewer stem cells, even in the bone marrow. And so, as we've been discussing, as we get older, if we don't watch our lifestyle and watch our diet, all of these factors that help to repair our normal healthy circulation become damaged. Now, the question that I was asked of me is really, well, how does that relate to cancer? Well, it turns out we pretty much, our body knows how to actually create homeostasis, a state of balance in the body. We have just the right amount of blood vessels. If we need a little more, our body knows how to figure out how to dump some natural fertilizer, growth factors to grow a little bit more, to heal up, for example, after a wound, surgery, or trauma. You have a little scab. If your scab ever fell off, you saw that bright red bubbling stuff. That's angiogenesis, blood vessel growing to heal up that wound. But after the wound is healed, basically the body mows down and makes sure there isn't any extra blood vessels that grow. Because we have extra blood vessels, we wind up actually developing problems where blood vessels can bleed in the eye for diabetes, diabetic retinopathy, or macular degeneration as we get older. Those blood vessels can leak in the back of the eye. Blood vessels can grow in the joints in autoimmune diseases like arthritis, and those can cause damage as well. But the most notorious situation in which excessive angiogenesis occurs is in cancer, where microscopic tumors that would normally be unable to grow because they lack a blood supply, over time, they acquire the ability to produce those natural fertilizers I talked about, normally used for healing. So tumors have been equated to wounds that actually don't heal properly and keep releasing those fertilizers. And remember, I told you normally the body mows down those extra blood vessels, but tumors are able to keep pumping out the fertilizer. These are angiogenic growth factors. And I worked in a research lab to discover some of those factors. There's more than 30 of them today, but when I started out, there was really only one. And those growth factors essentially hijack our normal circulation. It's like sprinkling extra fertilizer so that weeds will actually grow in the weed patch. And now the weeds or the blood vessels are growing towards the vessel, towards the tumor. And studies have shown that if you have an avascular microscopic cancer that's isolated from the blood supply, it can't grow larger than the tip of a ballpoint pen. And it stays there until your immune system cruises by, finds it, and takes it out. Kind of as Dr. Montgomery talked about, the special forces, the Army, Navy, Marines, kind of called into play. Special forces that are in our immune system basically are snipers that take out these microscopic cancers. But once blood vessels grow into it. Studies have actually shown that when blood vessels start touching a previously avascular tumor, and they start feeding that tumor with blood and nutrients and oxygens, that tumor can grow 16,000 times in volume in just 2 weeks. And that's actually what we see clinically, is that small microscopic cancers are white. They look white, they're avascular, not going to go very far. But the large ones you see in surgery, when a surgical oncologist operates on a cancer patient, these are big bloody tumors. And the same blood vessels that feed the cancer allow cancer cells to escape into the circulation for metastases. And most cancer patients don't die of their first or primary cancer. They die of metastatic disease. So what's really interesting is this emergence of the field of anti-angiogenic cancer therapies, which I've been involved with, that's cutting off the blood supply using medicines to treat cancer. It's another pillar of cancer therapy today. There's about a dozen of anti-angiogenic drugs developed by biotech. But what's really fascinating is that there's a number of foods that actually also have blood vessel controlling or anti-angiogenic activity. Among them, foods that we've already talked about, soy proteins from soybeans, isoflavones, the sulforaphanes from brassica, other substances from dark leafy greens, the carotenoids from carrots, the healthy omega-3 fatty acids, and also fibrous foods like nuts, or soluble fiber foods like mushrooms, all contain anti-angiogenic activities. And when you take a look at the epidemiological evidence, the consumption of these plant-based foods have actually been tied by association to the lower risk of cancers across the board. But if you look specific cancers, you can actually find which studies that cancers have actually been studied. Now, what's interesting is that we've actually gone back to the lab to isolate the molecules extracted from the foods and test them in the same systems that drug companies use to develop anti-angiogenic drugs. And we find, for example, genistein, diadestein, equol, which is found in soy and soy metabolites, powerfully shut down tumor angiogenesis. We find that sulforaphanes powerfully shut down angiogenesis. We found that ellagic acid from strawberries powerfully shut down angiogenesis. And so, again, while single mechanisms can't explain everything, the body's way too complex. There's sort of the wisdom of the body probably exceeds our ability to truly understand it. We're beginning to make some sense out of some of these early observations that came decades ago that Dr. Campbell's work, pioneered to give us a reason to believe, and not just a reason to believe, but a reason to act as a way of actually preventing cancer. And also, if you have cancer, to treat while you're being treated in the oncology clinic, because the other question was, what do we do during if we're actually being treated with cancer? There's health care that we do for ourselves between visits to the chemo unit or to the oncologist's office. And that's where we can actually consume some of these healthy substances as well. And a study of 700 patients collected by some of the top cancer centers, including Memorial Sloan Kettering, the Dana-Farber, MD Anderson, was presented at this big cancer conference, ASCO, the American Society for Clinical Oncology. And they found that patients with stage 3 colorectal cancer, so stage 3, it's a fairly advanced cancer, getting treatment, so regular, whatever the treatment that the oncologist is ordering, if they had 2 fistfuls of tree nuts, such as walnuts, macadamias, pecans, that in conjunction with treatment, there was a 50% lower risk in mortality. And so the outcomes were improved by actually having tree nuts. So this was published in the Journal of Clinical Oncology. It was presented as at a plenary at ASCO, the major cancer conference. And again, these are all pieces of the puzzle of the Sistine Chapel, which is 1,000 pieces all over the place, very difficult to put together. But I think, folks that are, on this panel, lots of us have been picking up little pieces and trying to fit them together. And that's what angiogenesis is. That's how it relates to cancer. That's how it relates to diet. And it's how it kind of ties together some of the things we've been talking about.
Dr. Lee, when you say that there are foods that had an anti-antigenic effect as good as the drugs. Are you saying that, I don't want to put words in your mouth, are they working as well? In other words, are you just saying they're helpful, or are you saying that broccoli sprouts and other sprouts and anti-angiogenic foods could possibly completely replace the use of a drug in fighting cancer?
No, that's not what I'm saying at all. What I'm actually saying is that as we study the benefits of food and diet and how it can influence cardiovascular disease, diabetes, and cancer, some of the biggest chronic health conditions facing our society today, and this is before COVID, I think we could probably hypothesize that dietary approaches will also help us resist COVID as this is going to go into the future. That food is an important tool in our toolbox. And we spend a lot of time assassinating foods by being bad for us. And in some cases, many cases, that's a deserved criticism of certain foods. But what we're beginning to understand is that there are many foods that, we know are good for us, plant-based foods, seafoods as well, that actually have reasons that actually can help amplify our body's self-defenses. So this isn't really about foods replacing medicine. This is using part of the wisdom that we've actually had to acquire to develop medicines to help us in a way understand and study how foods may be helpful as well. So this is really about having food being a useful tool in the toolbox, the same way that medicine is a useful tool in our toolbox.
Dr. Lee, I asked you this same question many months ago, but I want to just ask it again to see if there's an update. I was fascinated sometime early last year with the fact that the Mass General was looking at for patients who came in with a diagnosis of COVID-19, that they had 30 minutes of inhalation of nitric oxide 3 times a day. And then there was a sort of a sister study that was done with the healthcare workers themselves, where they had to inhale nitric oxide 30 minutes before the start of the day, and then before they went back to work. Have we gotten any further information on that study?
Yeah, I think that study is still underway, but what's really interesting is that there was a very specific study that got published at Mass General with inhaled nitric oxide in pregnant women with COVID who were looking like they were actually heading towards a ventilator or an ICU. And they actually got inhaled nitric oxide, and the study clearly showed that the power of nitric oxide was able to avert their decline, keep them from going to ICU or being ventilated, and to be able to rescue and get them out of the hospital. Now, what's interesting is asking what would that nitric oxide be doing in those people? So one of the things that we actually did, we actually discovered that the damage to the endothelium, as you've discussed, is pretty profound in COVID, particularly when people are sicker and sicker. They've got more and more endothelial damage. And so nitric oxide being one of those repair mechanisms, that may actually help to explain why inhaled nitric oxide was beneficial. Number 2 is that many of these people with thromboses, they had blood clots with COVID, that contributes to their clinical decline and their need to head towards an ICU setting. Nitric oxide is a wonderful vasodilator, which we know Viagra and Cialis also do. And so that might actually been able to assist them as well. I'm actually now involved in a conversation of a potential future clinical trial with a group that's in the UK, and they actually have a nitric oxide precursor that's in an inhaler, and that they're looking at for long COVID or post-COVID, the people who have recovered and are still having shortness of breath, to see if actually giving that nitric oxide precursor as an inhaler could actually help improve their healing within their lungs.
Wonderful. Yeah.
Okay, next question. Thank you, Dr. Lee. So the next question for each of you is, Dr. Esselstyn, do you recommend statins for people? Dr. Campbell, a lot of speakers today recommend whole food, plant-based diets, and they all sound very convincing, but there's also a whole bunch of keto, low-carb people who also have credentials, they're medical doctors, they're authors. What do the long-term studies say? When you look at all the unbiased, large, long-term nutrition studies, Do they show that whole food plant-based eaters have significantly less disease and live longer than people eating diets that include animal products? Dr. Montgomery, what have been the results over the last 15 years among the patients that you treated with the standard medical care for cardiovascular disease versus the ones that you treated with diet and lifestyle? What has been the difference in results? And Dr. Lee, two questions for you. How does alcohol affect our health? And what should you do if you do get COVID-19? What should you do if you got COVID 9 months ago, but the symptoms still haven't gone away, and you're one of the people they call that have long COVID? If you could each answer that, and I guess we could do it in order. We could do Dr. Esselstyn, then Dr. Campbell, then Dr. Montgomery, and then Dr. Lee.
Yeah, fair enough. Well, the statins were introduced in 1986, roughly. And what are we now? We're over 30 years into statins. And when the statins were invented, the leading cause of death of women and men in Western United States was cardiovascular disease. And that apparently that figure hasn't changed very much. So they really haven't quite been the revolutionary drug. And I was just recently looking at a study several days ago that was in the older patients where you had to treat 100 patients with statins for 2.5 years to spare somebody from having a single event. And there are some serious side effects with statins, and that is they can have severe muscle cramps. You can get liver injury. It can cause diabetes, and it can give brain fog. Now, what we have is I run every month. I have an intensive counseling seminar, usually for no more than 18 or 20 patients. And this is all done virtually. The patients seem to come from throughout Canada, throughout the United States, and some from overseas. And it's a very intensive single day, 5.5 to 6 hour study where these patients are going to learn all about how they have created their disease and precisely how we want to empower them as the locus of control to halt and to reverse their disease. And we kind of looked up what our batting average was with that group. Oh, and I should mention also, my secretary will give me a list of the patients who are attending the seminar, usually 10 days beforehand, so that I have an opportunity to personally call each of them myself so I can get my arms around their story. And at the same time, it will provide them with an opportunity to ask questions of me so that coming to the seminar, we have a strong platform from which we can all move forward. And what I have come to find, of course, all these patients, they're self-referred, and they all seem to have a cardiologist and very often a primary care physician. And we have any number of them, before they ever come to our seminar, they have learned that they cannot take a statin because of the side effects. And what we found, and we've looked this up, I guess the last time was in July of 2014, the Journal of Family Practice. We looked up some 200 patients, 2 of whom lost to follow-up, the 198 patients, of whom 177 were compliant with our approach. And it was really quite exciting to see that even those who didn't take a statin, as long as they were following our program, did absolutely wonderfully. As a matter of fact, there are several striking examples in my book, Prevent and Reverse Heart Disease, of some of our most profound reversals on an angiogram and also on persons who didn't take statins, of some of the most profound reversals. So I really try to work it out so that I don't ever get in a wrestling match with any of the physicians who are caring for these patients, because I would say that all of them who come to see us with heart disease are already on a statin, unless, as I've described, they cannot take it. And when they're taking this medication, or whether they're not taking it, people now, I think, have the confidence of what can happen with whole food plant-based nutrition. And here's how it works. When they leave our seminar, they go back and let's say 2 or 3 months later, their doctor does another lipid profile for them. And he'll say, my goodness, you really have, your hypertension has come down. You've lost 20 pounds. We're going to have to reduce or get rid of your hypertensive medications. My gracious, your diabetes has gone away. I'm glad you noticed that and reduced your diabetic medication. And it looks like we're going to have to really stop your cholesterol medication because your cholesterol is really gone out of sight here. And that way, over the last 34 years, I have yet to receive a single phone call or email from a physician saying, Dr. Esselstyn, how dare you teach my patient the healthiest diet on the planet? So I think where it comes down to this, almost all the studies on statins, when you think about it, all the studies on statins were done with what? With the control group was eating the Western diet. And I like to look at what's happened in ischemia for a moment. As you know, ischemia had 5,000 patients in it. And of those 5,000 patients, there were 3 groups: optimal medical therapy with bypass surgery, optimal medical therapy with stents, and then optimal medical therapy. And of course, at the end of 5 years, there didn't seem to be any difference in major events. But my disappointment with that study, although it may have been a little bit too challenging, I didn't think for a minute that what they called optimal medical therapy was optimal medical therapy. How many of those patients do you think for 5 years wasn't having a drop of oil? How many of those 5,000 patients over 5 years were eating 6 green leafy vegetables daily? Yeah, I mean, it's interesting. So anyway, the bottom line is that you're going to do okay if you can't take statins. And how many statin drugs do they take in the Papua Highlands, rural China, Central Africa, where there isn't any heart disease? Yeah, I think it's a bit of a crutch. If patients are on it, I don't take them off it. If they're not taking it, I don't start it.
Thank you.
So I'm next, I think, Steve.
Okay, yes.
Yeah. So the question concerning, the long-term effects of the so-called keto diet, I got to go back in a little bit of history that most people know. That obviously started with Robert Atkins back in the 1973s, as we generally know, who was actually at the time opposed to the emerging evidence coming up at that time, about a plant-based diet, using different terms. But in any case, he didn't particularly care for that. He did receive some funding for that point of view, I have to say. But in any case, he was interested in cutting down on carbs. He said it wasn't fat. It really wasn't fat that was leading to better health. It was the high carbs. So he devised this diet, low carb diet, very low, as many of you may know. And of course, when people go on that kind of diet, especially when they got weight to lose, they lose weight. Body fat is burned, keto bodies are formed, or ketones, if you will, are formed, and that kind of feeds into the cycle of depressing appetite. So appetite kind of stays down for a bit. And so, and also, I think a few studies sort of showed some decrease in serum cholesterol levels. That impressed people. That impressed some folks, at least, who wanted to believe it to begin with. So the keto effect became a little bit attractive in the short run. I think we have tended to see that over time. But the point is that most of the studies that I'm familiar with, not really very good studies, but nonetheless, people go off that diet within 6 months. It doesn't stay around. And so, yeah, they lose some weight. And as I say, everybody wants to lose some weight who's got weight to lose. So that's it. But the key thing about a keto diet, low carb, obviously is high in fat, high in protein. And by protein, that usually means animal-based food, animal protein. So the keto diet is exactly the opposite of what we're talking about here. And that leads to the question then concerning how long does this go on, kind of thing, this whole food plant-based diet. The data that I like to think about when trying to think about that question are mortality data over a lifetime. Because obviously, we're talking about end of life experience or later ages. And very clearly, the diet that is high in animal protein and high in fat,
Don't lose it. It's okay.
they in fact are higher in the various systemic diseases. They die earlier. So it's exactly the opposite of what the early effects of keto might indicate for some folks. It simply is the opposite. So the keto diet has no merit, no basis in, for sustained health, and should be avoided. I don't know how to quite answer that question about for those who want to lose some quick weight. I think there's some other ways of doing that without going down this keto track. But yeah, I think the keto diet, from my point of view, at least from the data I'm familiar with, is pretty well dismissed.
Thank you.
I think I'm next up. So the question is, in my experience over the past 15 years, standard medical treatment versus dietary and lifestyle treatment, which is done better. Clearly, our experience has shown a lifestyle intervention to be superior now. Most of our formalized data shows in the acute setting. Because of the nature of my practice, I'm treating patients who are acutely ill. And so a lot of our data shows the acute intervention of lifestyle versus medication. And so a lot of our published data, as well as our track data, covers a period of months. So we don't have longitudinal data, say, over 15 years. But what I can say anecdotally in my clinical practice, the patients that I've managed with the standard regimen who are not willing to undergo the lifestyle intervention, they do poorly compared to patients who over 15 years follow the lifestyle regimen. Now, when I say follow the lifestyle regimen, we have a pretty aggressive, precise, some people call it stringent, extreme lifestyle intervention. We put them on detox regimen. We put them on a regimen where they, can eat cooked foods for a certain period of time. They do intermittent cleanses and detoxes if they have a chronic illnesses periodically throughout the year. And we follow them regularly. And individuals who follow this regimen fairly closely do very well, because we found that we have a reduction in the number of pharmacological agents that they require. We also have a reduction in the amount of hospitalization, a reduction in the number of procedures, and even our patients who, quote unquote, fall off the wagon. So we follow them chronically and they fall off the wagon from time to time. They get off and they consume food. Today, I saw a patient who was in one of our nutritional boot camp classes many years ago. And, she knows how to detox and the like. And during the coronavirus, she was in the house and, she gained weight and wasn't feeling well. And she knew what to do. She went and did a nutritional detox and cleanse, and she lost weight and improved. So they gain a level of understanding because what we provide our patients early on through our aggressive nutritional cleanses is we provide them with an experiential knowledge. So once someone gains an experiential knowledge, it's something that you hold close to the heart. There's a maybe 6th or 7th sense of understanding for the benefit of what that is. So it goes beyond just the intellect, beyond reading some articles, but you gain personal experience and it has an extra dimension to your knowledge. And so a patient who obtained that, they carry that for a long time. And so what we have seen over longer than 15 years, about 2 decades, is they have reduced medication, reduced hospitalization. And these are patients with, near end stage heart failure who, have had bypass surgery in the past. One of my patients in his 70s, and, he's got 2 kids that are 2 years old now, as a younger wife. For me, they have a much greater quality of life and a much, greater longevity because they're following this regimen, as opposed to individuals who just simply turn this approach down. We have to add medication after medication, because what we're doing is we're only treating symptoms and we're not really addressing the underlying biochemistry and physiological problems that occur. And the origin of those problems really start at adverse lifestyle components, problems such as the bad food they eat, lack of fresh air, sunshine, and the like. So it's clearly hands down in our experience, and we published this data heads on with reduction medication, with a defined plant-based diet, and improvement in patients' clinical condition in the short run. And our clinical experience anecdotally shows the same to be present in the long run.
Mm-hmm.
Thank you. Dr. Lee?
Can you repeat the question? I think it was about COVID.
Yeah, two questions. How does alcohol affect our health? And what should you do if you have COVID? And what should you do if you had COVID 9 months ago and you still have the symptoms and you're considered a long COVID or long hauler?
All right. Well, the question about alcohol is a broad one, but kind of an obvious one. I mean, alcohol. There are some very decent studies to show that red wine and certain types of alcohol consumption regularly can actually be beneficial. But actually, most of those studies have also involved people that actually are eating better generally to begin with. So I would say, and the benefits are not due to the alcohol; they're actually due to the bioactives that are extracted by the alcohol in the beverage itself. Alcohol over time and at high concentrations has all kinds of devastating effects on our body. Everything from damaging our liver to stunning our bone marrow, including our stem cells, to impairing our brains, kind of pickling our neurons, to creating wreaking havoc in our microbiome. I mean, I think there's a litany of things that excessive alcohol actually can do. So, I think, and that's been pretty well established. So I would say, as a general rule, most people, most doctors are actually advising their patients to say it's fine to have a little alcohol. I mean, but not to actually have regular high consumption of alcohol. There's nobody that would actually agree that that's actually a good thing for you. With regard to COVID, this is still very much of a virus and a disease that we're getting our arms around, and we're still trying to understand it. I would say it's not really clear exactly what you do, because most people who develop COVID actually will recover, at least in the immediate sense of the word. Well over 99% of people will actually recover. They may not feel that well, but they'll actually recover. And even people who are vaccinated can be infected and can be under the weather, so to speak. But most of them will actually not die. What is sort of more troubling is that some people, initially we thought it was people who actually had comorbidities, elderly, diabetic, obese. And we also then realized that some of the more vulnerable populations included brown and black populations, and that may not be due to the color of their skin. It may be due to other socioeconomic aspects as well, seem to be getting sicker. And but now we actually know that it's much more than that, because we can't really predict who's going to wind up getting really sick from COVID. So younger people now are starting to get sicker. I was just reading earlier today that the largest, highest group of people getting COVID are a population in the 20s and 30s. And most of them don't get that sick, but they do get sick. And we also just began having reports that children who get COVID are now also reporting getting long COVID, or the post-acute sequelae of COVID as well. And so this is a disease that, almost at every turn is giving the medical community a surprise that we haven't quite seen before. So we're really working hard to actually understand. So I guess what I would say is this: you should get vaccinated if you can, and if you don't have a reason not to be vaccinated, because that's the safest way to get towards the light at the end of the tunnel, not only for an individual, but for society as a whole. Obviously, that's a free choice in this country, but we do know that vaccines for smallpox and measles and polio generally are how we actually move forward to improve our public health. We also know that the vaccines seem to have a very high protective ability, so that you can step over the line and largely be protected from dying, which to me is a win. If you do get infected, I would say, what we know is that you're probably going to recover at home. So you kind of take it easy and try to just recover. If you start feeling really crappy and feeling sick, it's better to get to the hospital. And we do know that there are monoclonal antibodies that have been approved for emergency use by the FDA that can actually make the severity of illness much less. And that's a treatment that, that people are beginning to talk about. And also, if you actually wind up being admitted to the hospital, let the doctors who are gaining experience now make the decisions of how to prevent you from requiring the ventilator. We're way ahead in this country, in America now, from where we were a year ago, where we weren't really sure what to do. I think that the save rate for people with COVID is actually quite good in the hospital, although, and I think here's another sort of hidden thing that people don't realize is that high death rates, like we're seeing in India, but also in Brazil and other parts of the country, and we saw in New York and other places, high death rates occur actually when our hospitals and our health systems are overwhelmed. And we've got too many people in a hospital that we can't take care of, and they're all acutely ill from different parts of COVID. That's really what was really starting to overwhelm us and leading to high deaths. So as far as long COVID, again, we don't really understand everything about this. The three things we are beginning to see in long COVID is microvascular damage to those endothelial cells that we've been talking about. We're starting to see that they have an autoimmune and a chronic inflammatory component, which, definitely is something that diet should and could be used to actually help to combat, not as the single cure, but really as something that needs to be paid attention to. And there are efforts now looking at that. And then neuropathy, there's problems with nerves that actually develop that we don't understand, whether it's the brain, spinal cord, peripheral nerves, cranial nerves, the nerves in our head, in our face. Those we don't really fully understand. So therefore, most of the people who are not feeling well after recovering from COVID, what I would recommend, go to your doctor, and if your doctor doesn't really know what to do, look for a post-COVID or long COVID clinic. There are lots of these clinics. Most of the major hospitals are beginning to create them. I wouldn't tell you they know exactly what to do yet, because they're just starting to collect the data and trying to formulate the hypotheses to understand how they could be helped. But, perhaps, Dr. Montgomery or Dr. Esselstyn, you have some experience with these long COVID patients that might be beneficial.
Yeah, thanks. I'd like to have a few comments, and thanks for your insightful thing. One, I'm going to throw some comments and questions, so make some notes, because this is a very pregnant topic. First and foremost, the concept of vitamin D. I think there's some data showing very strong correlation with very low vitamin D levels and mortality. Dr. Lee, you mentioned very insightfully that the survival rate of this disease, by and large, is better than 99%. Regarding the vaccine, and again, I'm not going to say I looked at every data on the vaccine. I looked at Moderna's data and I looked at Pfizer's data. And what I gleaned from that data is that they showed efficacy in preventing mild infection of coronavirus. This is a relatively young, healthy population. Median age in Pfizer's was 52. And there was no significant deaths in the control or treatment groups in either of those studies. So that means there was no survival benefit. That's number one. Number two, the elderly population was not well represented. Number three, people with comorbidities were not well represented. Pregnant women were not well represented. In Pfizer, they excluded patients who had already had COVID. I don't think they did in Moderna. I had one patient who had COVID, who was in Moderna. And I did not get a chance to look at J&J's data, although they touted a 66% efficacy compared to the other two, about a 95% efficacy. But the efficacy in these vaccines, based on the published data in the New England Journal, was efficacy in reducing mild infection by and large, not survival benefit. So if you have a disease state which is 99% survived with nothing, but the immune system, and we can all tout in our discussions, our population is a very sick population, so we don't have the healthiest immune systems to start with. So in a population of people with an unhealthy immune system and a 99% survival rate, just imagine what can you do if you give them more plant foods. As diligent as I am about 100% raw fruits and vegetables, if I say just increase the amount of plant foods, I think we can boost that survival rate even more. So in my practice, I see a number of patients who come in asking about the vaccine, and I only advise my patients based on their clinical conditions. So I'm not advising the audience. So I'm going to say to the audience, do what your doctor says is best to do. So I'm going to preface my statement with that. But certainly in my practice, I don't lead with recommending the vaccine. Personally, I haven't gotten it, but the reason is not so much based on any theories or crazy things on the internet. It's based on Pfizer's data and based on Moderna's data published in the New England Journal. And what Pfizer says about their vaccine, what Moderna says about their vaccine, is that it does not improve survival. That's the message from Pfizer, message from Moderna, based on their publication. So based on that, and I have someone who has a disease state that's 99% survival, when we have other therapeutic interventions, such as a plant-based diet, which boosts the immune system, we can all agree that a healthy immune system, with or without a vaccine, if you have a very poor immune system, I don't care what kind of vaccine you have, a vaccine relies on stimulating an immune system that has to have some capability of fighting a bacteria, virus, or whatever you're trying to immunate the person from. So you have to have a healthy immune system to start with. That's number one. Number two, we can do other things to stimulate. Ivermectin is a drug that no one talks about a lot. There's a lot of published data, and I'd like to get your input on this across the different countries. Now, there's no large randomized multi-trial data. That's the criticism it gets. But there are small randomized studies, about 38 that I've counted, that's shown survival benefit of 93%. Ivermectin, as you know, is a drug that's been on the market for over 40 years. It's nearly 4 billion prescriptions given, and only roughly 16 reported associated deaths, which we're not quite sure of. And it was on the World Health Organization's one of the most important drugs around, a very low side effect profile. And I've used it prophylactically in my patient population, also therapeutically. And we've seen great data. There are many critical care physicians who've seen great data around the country with this drug. So the safety profile is much greater. There is some survival benefit compared to the vaccine, which I'm not aware of it having survival benefit. It has reduction in infection benefit that I've seen in the published data, but not survival benefit that I've seen. And so that's why I lean more toward natural approaches first and foremost. Ivermectin, hydroxychloroquine has also benefits as well. Ivermectin head-to-head with hydroxychloroquine, ivermectin was proven to be better. But I think there are many tools we have, and I have treated some patients with this long COVID syndrome. Long COVID syndrome is reminiscent to me of a post-infectious sequelae. I had a number of patients in my practice over the years who will give me a history of a viral infection. One patient comes to mind off the hand. He was sitting in a movie theater and he was next to someone who had a cold or flu and they were sneezing. And a few days later, he was sneezing and he had a viral infection. Long and short is this. Shortly after that, he had this severe neurological problem where he came into my office and he can hardly walk, had nearly paralysis in his lower extremities. We did a number of tests, and based on that history, I hypothesized, look, you have some kind of a post-infectious sequelae. It was an autoimmune disease that affected his nerve system. We have textbook cases of this, strep throat, for instance, again, a post-infectious sequelae, when you have autoimmune effects on the heart, autoimmune effects on the kidney, autoimmune effects on the liver. So these disease mechanisms, they don't always come with titles and great textbook cases, but they present themselves in very vicarious ways. So post-infectious sequelae in the setting of this patient with another virus, I think we're seeing a similar thing with COVID and the long COVID syndrome, where patients have an exacerbation of, say, an underlying chronic illness, or they can have a neurological complication. They can
Please
have a
welcome to the
cardiomyopathy of the lung.
2021
So you have situation with a post-infection where the immune system is tripped up and there's an autoimmunity. You could have an infectious autoimmunity, a pathogenic autoimmunity caused by a primary infection. Some people talk about pathogenic autoimmunities caused by vaccines, but it's a very similar mechanism that we're seeing with these long-term effects. So what I try to do is I try to do things that go against the autoimmune process, because as we all talked about, these similar mechanisms, inflammation, autoimmunity, triggering different types of cytokine reaction, They can happen with an infection. They can happen with a pseudo-infection called a vaccine. So what we need to do is go to the natural state of immunity with natural food, natural detoxification, also more benign drugs to treat an acute infection. Ivermectin is only used for about 7 to 10 days. People get better in just a couple of days. All of my patients are getting prophylaxis with ivermectin plus quercetin and zinc, vitamin C, vitamin D, all of these things up front to help boost the immune system in addition to a plant-based diet.
Thank you. Dr. Esselstyn, would like to answer your question.
I'm sorry?
Would you like to answer your question? Were you next?
I think I answered. It was about statins.
Okay, I'm sorry.
Yeah, I think I did that already.
Okay, so everyone answered their question. I'm sorry. Okay, so next question. Dr. Esselstyn. I guess the question for you is, where do you stand today in terms of fat? Many very respected whole food plant-based authors continue to say that there are benefits to avocados, raw seeds, raw nuts, and raw olives. And in some cases, they say there's also benefits to oils such as hemp, flax, walnut oil. And many of them, claim over and over that there are significant benefits. And that even if your studies worked without using these nuts, they're saying that they might have also worked just as well if you had used avocados, seeds, nuts, and olives. That's your question. Dr. Campbell, your question is, what is the impact of nutrition on preventing prostate cancer? Does that specifically, have you seen studies showing that lifestyle and diet affects prostate cancer? Dr. Montgomery, your question is, does a whole food plant-based diet automatically bring your cholesterol level down to a healthy level? Do we want our cholesterol below 150? And then also, does a whole food plant-based diet, in your experience, prevent against all heart attacks and strokes? Dr. Lee, Professor Thomas Seyfried says that glucose and glutamine feed cancer. Does this mean that we should avoid all fruit since it has fructose in it? And how can you avoid glutamine? Also, should we try water fast and green juice fasts to help beat cancer? So if we could go in order, I guess Dr. Campbell, Dr. Montgomery, Dr. Esselstyn, and then Dr. Lee.
Can you repeat that quickly, Steve?
Yes. Does a whole food plant-based diet and lifestyle prevent prostate cancer?
Yeah. Two studies come to mind. One by Ed Giovannucci at Harvard some years ago. And he was able to show a really impressive relationship between the consumption of skim milk, of all things, and prostate cancer risk. That was a very impressive thing. Some others have followed up on that same idea. The other study that I have in mind is Dean Ornish, that Dr. Esselstyn referred to before, that were able to show some benefits from, and prostate cancer going on to, take the blood cells out, see what's in blood cells and that sort of thing. So prostate cancer behaves in a rather similar way to some of the other reproductive cancers, at least epidemiologically. And dairy seemed to come into play, on that one as much as anything else. And so, prostate cancer is just one of them that's going to behave, in my view, just about the same as heart disease and many of the other cancers as well. Nothing special about it.
Thank you. Dr. Montgomery?
I'm sorry. The question is, I'm gonna repeat it, make sure I have it right. Does a whole food plant-based diet prevent heart attack and stroke totally? And what was the other part of that? Can you remind me of that?
And does a whole food plant-based diet automatically bring your cholesterol level to a healthy level or below 150? And do we want our cholesterol level below 150?
Okay, great set of questions. One thing, I remember taking standardized questions, and whenever you ask these, foils that have absolutes, you tend to avoid the absolutes, and I'm going to avoid the absolutes. And here's what I'll say. A whole food plant-based diet is at the core of a healthy lifestyle. But there are many aspects of a healthy lifestyle. The reason we started for a long time putting emphasis only in whole food plant-based diet. And oftentimes, patients would say, well, what about exercise and all of this? I think those things are important. But what I found with the nutrition part is that people were addicted to bad foods. And so, we get in, so eat a healthy, diet and plant-based, et cetera. And if they get me off in the trail of exercise and proper sleep, they'll come back the next week and say, I'm exercising more, I'm still eating cheeseburgers, but I'm exercising more and sleeping better, whatever the case may be. So we really got at the core of what people were addicted to first and foremost. So what we have found in our practice is that there's a big part of heart disease reversal, heart disease, and stroke prevention in plant-based diet. However, there are many other aspects of our lifestyle that can have an impact on these disease states, excuse me, such as stress, lack of sleep, and various other things. Now, once someone's on a very healthy diet, they tend to tolerate stressful events, situations better. They tend to sleep better initially. So once you change your internal biochemistry, you tend to perform better in these other areas. You're more able to exercise and the like. So starting at that core is very, very important. So I would say my answer is that a large percentage of heart disease would be treated, heart attacks and the like. But I'm going to leave a little bit of extra for someone who's doing something crazy that could make it extreme, such as smoking a lot despite eating a whole food plant-based diet, or drinking too much, as Dr. Lee pointed out earlier, that could have an adverse effect on the heart, or doing other things. And oftentimes patients will come in and say, I'm eating a whole food plant-based diet, and I don't know what that means. Are you microwaving all your food? Or are you grilling all of your food? Maybe you're not having oil, but you're eating processed foods out of a can that has chemical preservatives and the like. And if you're trying to reverse a chronic illness, you have to be much more pristine with the diet than that. And so I will say no, in the sense that the whole food plant-based diet, I want to make sure I know what they're eating. So I don't want your audience to walk away and say, okay, I'm eating a whole food plant-based diet, but they're eating chemicalized foods or packaged foods and things like that. I don't think that's what we mean when we talk about whole food plant-based, but everyone may not carry that level of understanding with them. And there's always a residual case for someone having a problem. To the cholesterol issue, again, elevated cholesterol, as I see it, is a metabolic problem. It isn't just a problem with eating too much fat and cholesterol. I've had patients who are eating a plant-based diet, their cholesterol is elevated, and we'll make change in their diet related to how they prepare the food, and the cholesterol comes down. We'll make changes in their diet in terms of being able to wean a medication or two, and the cholesterol come down. I've had patients on a certain medication have adverse liver effects, and we take them off that medication, the cholesterol come down. So I see elevated cholesterol more of a complex issue than what we really know. Yes, removing animal protein and animal fats from the diet can bring the cholesterol down. But consumption of animal protein, animal fats, animal protein consumption brings many more toxins into our system than just the fats from the animal. And so the chemical preservatives, the antibiotics, does it have an effect on the microbiome? So there are many complex, multidimensional problems that we have when we consume animal protein and other processed foods in our processed diet that can have an adverse effect on our liver, such that, cholesterol metabolism can be impaired. So a whole food plant-based diet, yes, will bring the cholesterol down in the vast majority of people because you're removing one of the major toxic sources. But I have to leave room for that a small percentage of people who may be on a certain medication or some other substance that they're consuming, whether it's a supplement or whether the like, that's having an adverse effect on liver metabolism that may be elevating the cholesterol, and we have to address that problem as well. Regarding the cholesterol level of 150, this was a question that came up in my presentation earlier related to cholesterol level 180. I really like to treat patients in totality and not just numbers. By that, I mean this. We can look at a study and show that, yeah, people with a total cholesterol level below 150 are heart attack proof. However, I may have an individual with a cholesterol level that is say 190, but maybe they have familial hypercholesterolemia and they used to have a total cholesterol of 400. I've had that happen. And so they're doing a lot of positive things lifestyle-wise, whole food, plant-based diet, exercise. We've reduced a lot of the medications and the like. And so I may not add another drug or supplement just to get that number down. I will follow that patient over time and look at the totality of that patient in terms of their risk factor. What is their inflammatory markers? What is their unstable plaque risk score, and various other things, the troponin level, how much myocardial stress is happening. So I look at a lot of biochemical parameters in the totality to make sure that this patient is going in the right direction, because one number does not tell the whole story, and it's only a part of the biochemical, the complex biochemical process.
Thank you. Dr. Esselstyn.
Yeah.
Can I add one comment on that low cholesterol question? Because when we did the China study now 30, we're raised 40 years ago almost, at that particular time, there was some really kind of very weak evidence that supposedly people less than 150 had a higher rate of colon cancer for one. And there was one study suggested that, wasn't convincing. Another one, of all things, a higher rate of suicides, which is kind of crazy. And so the idea got out there that going below 150, I remember in those days, was suggested as not being wise. When we started to get our data from rural China, and this is for 6,500 people, quite frankly, it's a good sized number. We saw cholesterol levels more than half being below 150 by far, 2/3. I was worried about it a bit. We went back then, as a result, went to 2 more labs to reanalyze those samples, got the same results. So at the end of the day, what we had a range, there's a range of means for villages in this particular case. It went from about 88 to 170, 88 to 170. The mean was 127. And so here's 2/3 of that particular population, actually with the low cholesterol levels, rarely seen any heart disease that Dr. Esselstyn referred to before, to some of the data he happens to have seen. So as far as low cholesterol levels are concerned, from an epidemiological point of view and some other considerations, I don't think that's a problem. I think it's overstated. That was an old issue once rumored to be a problem, but I don't think it's true.
Thank you.
Just to follow up on Baxter's comments, I would agree that no number has ever caused heart disease. And I try to tell the patients that what is causing their heart disease is any morsel that they eat that has the capacity to injure their endothelial production of nitric oxide. And that, I think, is because everybody has a different thermostat in their liver, and they're going to make either the cholesterol below 150 when they're eating this way, or it may be 180, 190, or 200. But they're not going to have heart disease unless they're injuring their endothelial production of nitric oxide. Now, I was asked to make a comment about nuts and avocado. And first of all, fat is absolutely essential in the diet. And in the foods we ask patients to have, to eat, they're going to eat all these marvelous whole grains, plenty of fat. They're going to have all these marvelous legumes, lentils, and beans, 101 different types of legumes, as I mentioned, plus red, yellow, and green leafy vegetables, white potatoes, sweet potatoes, and some fruit. They're not going to be at all fat deficient. The fat that we do take away is usually the fat that is associated with injury to the endothelium. So I don't like them to have any oil. I wrote a paper that was published in 2019 in the Journal of Disease Reversal and Prevention on on oil. And it says, is oil healthy? And I went over the animal studies and the human studies, how the oil injures endothelial cells. Now, nuts and avocado. Yes, in my book on page 69, it says very clearly, patients who do not have heart disease, I don't have any problem with their having nuts. Once they have heart disease, I feel that if you then give them the green light, nuts are so addicting that if they ever hear Dr. Esselstyn say it's okay to have a few nuts if you've got heart disease, what you're going to have is this. You're going to have There'll be nuts in the glove compartment. They'll be in the bathroom, the bedroom, the kitchen, the workbench. They'll be all over. They are highly addicting, and that's a lot of saturated fat that I don't want. And the same is what, maybe I was a little tough on the avocado as well. But having a program that is designed so that we do not at any time injure the endothelium has really given us, I think, results that we are happy to compete with anybody on the planet. Whether you want to look at our angiograms, whether you want to look at our pulse volume studies, whether you want to look at the reversal of the PET rubidium dipyridamole scan, it's been very exciting and very successful. Now, the other conflict that I feel is a little bit in a lot of these oil studies is the following. If you look carefully in the authors, there's so often they seem to have relationship to the oil industry or to the nut industry. And the late Arnold Relman, who was an editor of the New England Journal, has felt that that kind of association is absolutely inexcusable. Now, the other thing that is a little bit problematic for me with when people go a little bit crazy on nuts, I have yet to find a single study in the literature where you take patients who are seriously ill with heart disease, give them all the nuts they want, and have the disease halt or reverse. The study that I do know about is Predimed, and Predimed had 3 groups. They had Mediterranean diet with oil, Mediterranean diet with nuts, then the so-called low-fat diet. Now, to be a requirement to be part of that study was that you could not have a history of any cardiovascular disease because you were entered into the study. But lo and behold, what happened after 5 years? In the study with Mediterranean diet with nuts, 93 major cardiovascular events, heart disease, stroke, and death, and 96 events, and those with the Mediterranean diet with oil, and then 109 in those who had the low-fat diet. So really, adding nuts to this group that didn't have heart disease didn't turn out very well. And I think that in the interest of time, I'll wrap it up at that point, except to say that I again will invite anybody who wants to look at our long-term study on, was in 2014 Journal of Family Practice. We looked at those 200 patients, and 177 who were compliant had 1 further cardiac event over 4 years. The 21 patients who were not compliant, 62% had events in follow-up. Thank you.
Dr. Lee?
Could you repeat the question again?
Yes. Professor Thomas Seyfried said that glucose and glutamine feed cancer. Does this mean we should avoid all fruit since it has fructose in it? And how can you avoid glutamine? Also, do you have any knowledge or experience about water fast, green juice fast? Do either of them help to fight or beat cancer?
Let me answer the last one first. I don't have any experience with green juice and cancer treatment, so I don't have anything to say about that. The question about Thomas Seyfried's studies looking at glucose and glutamine, it is true actually that cancer cells seem to thrive when you introduce glucose to them. It is also true that studies have been done looking at the correlation of blood glucose and cancer progression and aggressiveness. And so I think that the body of evidence that's out there now with research does show that hyperglycemia actually is a risk factor for a poor outcome in the treatment, in sort of the status for a cancer patient. about the issue about fruit is more complicated than simply having sugar or not having sugar. The fact of the matter is that most fruits have a lot of other things besides fructose, and not all fruits have the same amount of fructose. And so, like everything in life, it's sort of about trade-offs. It's true that you can actually you can avoid fruits if you like and go straight to a vegan diet. But I can tell you that so far, cancer patients who go on vegan diets still die. So that's also not a magic bullet, silver bullet approach. They still die of their disease. So I think that we don't have the definitive answer yet of how to actually use cancer for diet, but clearly having more foods, plant-based foods with bioactives that can actually activate bodily defenses that actually fight cancer have been beneficial, and including there are studies that correlate the consumption of certain fruits as well to improve cancer outcomes, lower risk of cancer as well. And I think Dr. Montgomery actually said it really well, which is every patient needs to be treated in their own individual situation. So it's really difficult to kind of hand wave and create a generic policy or best practice for every cancer patient. So I guess how I would sum that up is to say, fruits have a lot of other things that can be beneficial to fight cancer besides fructose, which might not be that great for cancer. And so it's not really clear that cancer patients should avoid all fruits. And in fact, there are some studies that actually show fruits to be beneficial. A great example of a fruit that's been beneficial, in fact, is tomatoes. Tomato is actually a fruit, and it's been shown to have some benefits for people that consume them for lowering the risk of prostate cancer.
Thank you. If you would each take a minute and a half to make a final closing statement on anything you want to leave us with or wrap up with, or any final thoughts at all.
Yeah, Dr. Esselstyn, I would like to say that, first of all, I want to say thank you again for the opportunity to be with such distinguished colleagues and friends. And again, to congratulate you to Steve for really putting together this really wonderful symposium, and think of the information that you have shared with so many who are listening to what you have to say. I would just wrap it up by saying that I guess the reason that I find myself 21 years since retiring from surgery as passionate as ever about cardiovascular disease, and actually what I really see as the seismic revolution in health that is on the horizon. And that seismic revolution in health that is on the horizon is never going to come about through the invention of another pill, another procedure, or another operation. But the seismic revolution in health will come about when we in the profession have the absolute will and the grit and the determination to share with the public what is the lifestyle, and most specifically, what is the nutritional literacy that will empower them as the locus of control to absolutely annihilate chronic illness. Thank you.
Can I jump in here to be next one? Because I think what Dr. Esselstyn just said is perfect, absolutely perfect. I totally support what you just said, and I'm sure the colleagues would agree with that. But I would add the additional comment too, having been in nutrition all these years, that's one topic that's not even considered by most people to be a medical science. It's time that needs to stop. We got 27 institutes at NIH, for example, devoted to various and sundry specialty health problems. Not one is called the Institute of Nutrition. There's been discussion here in just the last 6 months or so that there's a new nutrition program, so it is said. Some advertisement of that is in the press. Quite frankly, it's been tucked away in the director's office. And the director of NIH at this particular point in time, this was done once before and it failed. The director in this particular case is a geneticist, a very famed, very qualified, reputable geneticist. And so when we take a nutrition program, tuck it into a budget to compete with genetics is not going to work, is going to fail. So I think we need to take this science, respect it, do something about making sure that the public get informed. Just as Dr. Esselstyn just said, it's critical.
Thank you.
Well, I'll jump in here. And again, thanks, Steve, for having a great program, of course, and then thanks for inviting me again. I always learn a lot, and I watch your programs online as well. So I get a lot out of these conferences, and again, thanks to each of my esteemed colleagues. I've learned a lot on this panel, Dr. Lee, Dr. Campbell, Dr. Esselstyn. Thanks for your kind words and insight. My comment is to the general public. We're in a healthcare crisis, and I want to commend everybody who's attending here, everybody who's going to pass this information on, because our healthcare crisis is going to be solved by us at the grassroots level. And I see this as a grassroots approach to this problem. Each individual is going to be empowered with knowledge that they're going to walk away with from this conference. They're going to pass that information on. And from the grassroots up, we're going to make these changes. We're going to make demands on our commercial industries to provide better food. We're going to find our own better food. We're going to plant gardens in the backyard. And we're going to do things that are more natural. Food is a big part of the issue, but getting outdoors, more green spaces, more fresh air and sunshine, removing more toxins from our system. These are the issues that we have to address individually and collectively. And so, as I often have stated over the years to individuals in my boot camp classes and the like, I think this is a movement, and I'm recruiting everybody who's within earshot of this to join the movement, pass on whatever knowledge that you've obtained from this conference, because together we're going to have to take this and move this information forward. It's not a top-down process; it's a bottom-up process, and it starts right here in meetings and conferences like this.
Thank you.
And I guess I'll close out with my comments to first thank my fellow panelists, who I always enjoy being in the company of people that stimulate me to think, and have done a lot of work that has been inspired countless of other physicians and researchers and nutritionists. And I do think that we are at a turning point. But as Dr. Campbell actually said, we still have a long way to go. I'm going to put a little plug in for his book, because I wrote a little ditty for it. If you ever want to hear from the point of view of somebody who's been through the battles of nutrition, read his book, The Future of Nutrition. It's excellent. It's got his characteristic wit. It tells us something about the history that we've been through, and it also sets the tone for the future. And I think that future does involve a grassroots movement. And I would just end by saying that, look, I'm a physician as well as a biologist. And when it comes to food and health, it's not just about the food. We've asked about the avocado and the green juice and about one thing or another. It's actually not only about the food, it's about how our body responds to what we put inside it. When we put something good inside it, it's going to respond well. When we put something bad inside it, it's going to respond in ways that are not so good. And so to that end, we need to actually pay attention and respect our body more. And I think that's where health is ultimately going to start from the inside out, not just from the outside in. Thank you.
Let me just say in conclusion, since I'm the only one with the microphone, and there's a lot of people that would like to have a chance to say this, not just for tonight, but for all of you, we're very grateful to you. Dr. Esselstyn and Dr. Campbell, you're 87 years old. We appreciate that you've spent your life in service. I know you could have worked on Wall Street and spend your life trying to be investors. You spend your life completely in service. Dr. Lee and Dr. Montgomery, the same. We are grateful to you. The world has a lot of problems, and we're really desperate to get good information. And the fact that you provide it for free, that you spend your lives doing research and you study, and you have such a high standard of what's accurate so that we could get information. If you didn't do it, I don't know where we'd get the information from. So I would like to thank you, and I'd like to unmute everyone else so they can also thank you as well.
We're going to have an
Thank you so much.
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 Thank you very much.
Come on, expand it.
Thank you so much.
Thank you.
Save the world.
Such a blessing to everyone.
Panel, thanks from Madison, Wisconsin.